to give a lecture, and I'm very humbled and grateful for the invitation. So those who don't know me, I work in Southampton, and this is a patient of mine that dislocated their knee on the field playing rugby football, and they also had a nerve injury, but we'll come to all of this in a while. This is where I work in Southampton, and one of the things that Southampton is famous for is the Titanic. And knee dislocation gives me this sinking feeling that this Titanic has now hit the iceberg and all there is trouble ahead. So what I want to do is start off with a story. So this story happened just 3 months ago, in late September. A 30-year-old female fell down the stairs at home in the morning and was brought into a hospital not too far from my hospital. They did an X-ray, and this is what they found in the X-ray. I don't think it's difficult to see that this is a dislocated knee. So this was about 2 o'clock maybe in the afternoon. They reduced the knee, and as you could see, the knee's reduced there. The patient now, probably about 2:30, 3 o'clock, was still complaining of a bit of pain, but the X-rays are as you see them. So I'm going to just stop the share and just ask, what would you do next? So Rami, if you could run the poll. Is the poll going to
Dr. Rami, you are muted, Dr. Rami. Can you run the poll?
Yeah, I'm just requesting Mr. Hussam to do it for me, please.
Hussam, please run the poll, Hussam.
Dr. Muhammad?
Run the poll, please.
Okay. Yes, sir, I do.
So just an idea, what do you think the next step should be? Okay, shall we end the poll? What did everyone think?
End it now?
Yeah, end it now, please.
Okay.
Okay, so I'm really pleased, and this is the only really message. If in 20 minutes, there's one message that I could just maybe convey, and that is exactly this, that we should do CT angiogram, because they did a CT angiogram, and this is what was found, a block. However, the timing of finding this and then revascularizing it was almost 24 hours. And so the final result of this patient was this. So a relatively straightforward knee dislocation, complicated by a vascular injury that had delay in treatment for a whole number of reasons, and each system has its own reasons. The end result is in a 30-year-old female losing their leg. And I think this is important, that I wanted to show you a complication in my world, around my region. So this is nothing about first world, second world, third world medicine. This is a complication around my area, around my region in the UK. So this is still happening. So just the one single message I would say is, if you see a knee dislocation, Yes, there's ankle brachial indexes. There's all sorts of things that people say that you can do. But please, 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 if it's available, get a CT angiogram. If it shows a problem, please ask your vascular colleagues to deal with it immediately, because it's not something that they may come across very often. And maybe you just need to impress that this can be quite a significant injury. So that's the most important. If nothing else, you can all go have a cup of tea now and not have to listen to any of the rest. If this is all I can say that please be careful of, is the vascular injury after a knee dislocation. So this is another patient of mine who is 74 years old. It's not this patient, but this is what she was doing. And she dislocated her knee. She also happens to be the wife of a recently retired and senior anaesthetist in the hospital. So I had about 8 or 9 different phone calls from the chief executive to colleagues saying, please, you must look after this lady. So not only a case in itself, but lots of other pressures. But the important thing is she was very, very active. This is what she was doing. She was doing chariot racing. She fell off and dislocated her knee. And this was her in resuscitation. After it was reduced appropriately, CT angiogram was normal. It's very difficult to actually analyze stability in a knee. And with her, I did take her to theatre, and you can see how much that knee's opening up. You could see on the lateral, you could see an anterior draw and a posterior draw. So essentially what she had is her PCL was gone, her posterolateral corner has gone. I won't do another poll, but I think at 74, initially I was reluctant to do a PCL reconstruction. She'd also fractured her opposite ankle. So we waited about 1.5 years, and I just thought the PCL will be okay, the posterolateral corner will settle down, and I was mistaken. 1.5 years later, she was still unhappy. So at the age of 75 then, I did a posterolateral corner repair, I did a PCL double bundle reconstruction, and her Oxford score improved significantly. She said that her life had come back and she went back to doing all activities. Now, the thing is, if you look back, her cartilage service is good. There were people who said, why don't you do a total knee replacement, a hinged knee replacement in a 74-year-old? But for me, with someone with so active, with good articular cartilage, I treated her more on her activities and her overall self rather than just chronological age. So it's not just one size fits all. And sometimes you do just have to listen to the patient. And if this patient came again, I wouldn't make her wait 1.5 years. As soon as the ankle healed, I would have gone and done this posterolateral corner PCL reconstruction. So my management plan, to summarize, is, of course, these are high injury, high energy injuries. So you do a full assessment to make sure there are no other life-threatening injuries. It's really important to check the neurovascular status for 2 reasons. Number one, so you can deal with it. And number 2, if they've already got some sort of neurology and you operate on it and it wasn't picked up before, you will be blamed for doing the neurological injury via your operation rather than the injury being blamed. And these people have a high incidence of having nerve injuries. So that picture I showed right at the start in my introduction with the one on the rugby field, on the football field, sorry, he was a soldier. He had a really severe common peroneal nerve injury. He got back to full activity, but he couldn't go back to work because he had a foot drop and he didn't want any tendon transfers. So the nerve injury is an important thing to rule out. You may need to do an examination, an MUA of the knee, and you must do a CT angiogram, in my opinion. And then if it's stable, you can put it in a brace, you could put it in a plaster. If it's unstable and needs vascular repair, you can put it in an external fixator. I think it's important to obtain an MRI before doing anything interventional, so you know exactly what the injuries are and you can plan your surgery. Most of these knee dislocations present the problem of the multi-ligament injury knee. And this is complex and challenging. You must do a careful examination. You've got to exclude vascular injury. I keep saying this and I make no excuses for saying this, because this lady that lost her leg isn't the only amputation that we've seen over the last 2 to 3 years. The one before that had a pseudoaneurysm and it wasn't treated well in time with the vascular surgeons, and they lost their leg as well. The nerve damage, and if you need nerve conduction studies later on, then that's fine, but it won't tell you anything immediately. Sometimes an MRI or an ultrasound can show you whether the nerve is completely ruptured, and you need your plastic surgeon colleagues in that case. Also look carefully for any meniscal or chondral injuries. This includes root injuries and ramp injuries. That's not the subject of today's talk, but you could do a lovely reconstruction of all the major ligaments, but the patient still be unstable because you've missed a root injury or a ramp injury, or even both. In the case of root injuries, they can progress to rapid degenerative change. So please do assess the menisci, be prepared to do meniscal surgery, including root repairs. These are, apart from I showed you the extreme of my 74-year-old chariot racing lady, but on the whole, these people are young. So you want to preserve the meniscus, and there are lots of devices to help relatively complex meniscal injuries be repaired. And this leads me on to one of the other key things is this is complex surgery. And if you feel that perhaps this is something that you would manage best with another colleague who does as many or as much, do share the operation. It takes a lot of the pressure off as well. Often these injuries, it's good to do as a 2-consultant or 2-surgeon procedure. If not, then the most experienced person with the skills to do the soft tissue reconstructions as well as the meniscal reconstruction should do the case. But there's no harm in doing this as a combined procedure so everyone's experience increases. Again, I resisted the temptation of doing a poll, but in our hospital, we may get 8 to 10 of these a year. I don't know how many each of you treat, but there's some people have a big practice where everything gets sent to them. But even in a busy hospital like ours, we'll get 8 to 10 a year. So if everyone just does one case, then it's not really good for the patient, which is who we work for in the end. Now, I would suggest that all injured structures should be treated in the same sitting. And that's because when you're tensioning the structures, if you have them all together, you can balance the knee. Otherwise, it becomes very difficult to balance the knee when you're doing a multi-ligament where you've done the posterolateral corner, PCL and ACL, where to tension. What you could do is keep the knee in a reduced position. You can have an X-ray to make sure it's neutral, and you can tension the ligaments appropriately. Again, exactly how to do the operation is not the scope of this talk, but there is a particular sequence to tension the knees in so that you get good stability through extension into flexion, and that involves understanding of all the ligaments that give stability with the knee in extension, and all the ligaments and soft tissues that give stability in flexion, and therefore tightening them appropriately. You've got to have good, clear rehab protocols. You have to work with the physios. They've got to know exactly what you've done, and you have got to trust them, and they need to have open channel of communication with you so they can say, what do we do? When can we start moving them? Specialist braces, like there's the jack brace and various braces, each have their own abilities to have mobilization and protocols that are different, but you in your mind must give clear guidance as to when you want the patient to move. And don't be tempted to go for complete safety and keep them shut down and in a plaster for too long. Early mobilization can give a good functional result. Otherwise, you get a very stiff knee. So the initial assessment, again, I keep coming back to this, make sure there's no life-threatening injuries, make sure the vascular status is okay. And the only real way to do this is a CT angiogram. Yes, ankle brachial plexus index can be used, but it's not as reliable. Reduce the knee immediately if you can, get a CT angiogram, and you can assess stability in theatre and whether you need to put an external fixator or not. Not every knee dislocation needs an external fixator. And when you get tibial plateau fractures or Schatzker 6 fractures, also think, could this have been a knee dislocation? And again, in our hospital, we have a clear protocol that any Schatzker 6 gets a CT angiogram. So this gentleman, he's the soldier. He got back, he had posterolateral corner, double bundle ACL, double bundle PCL, ACL reconstruction. He's back to doing everything he wants except for being a soldier. And that is not because of the stability of the knee, but it's because of the nerve injury, although he did have a nerve graft. Classification of knee injuries is really straightforward, and it depends on the number of ligaments that are injured. And the knee dislocation 5 is a dislocation and fracture. For those injuries that maybe not have been treated initially and come to you down the line, like say in my instance when I left that 74-year-old lady for a year and a half. And like I said, it's always good to share your mistakes rather than your good results, because hopefully in this way I learned from it, and hopefully I can say what I, perhaps avoid it for someone else. Always do get a long leg alignment view. And if you've got a posterolateral corner and the knee's in varus, you must correct the varus as well. Otherwise, your reconstruction will fail. The timing of surgery is a subject of debate, really, whether you go straight away, but early, I mean within 3 weeks. There's these papers that some people have shown no difference. Some have shown that if you go early, you get more arthrofibrosis. On the whole, I think knee surgeons who do a lot of ligament reconstruction would prefer to go earlier rather than later, so that the joint can be mobilized. And the difference has become, we've got better at doing these operations, and we've got better braces, and we've got better physios. So we can actually get these people going earlier. So if we delay it too much, that in itself can give fibrosis. Issues of patient selection, whether there's injury to one major ligament, knee ligament, whether they're active, soft tissues need to be settled. We've got to have an assessment of all the injuries. So the other, if the other ankle or the other fractures will affect rehab, then you may slow down. As I said before, I believe that we should try and treat all the injuries in the same procedure. Obese patients will have a higher complication rate, but if they've got a completely unstable knee, also need stabilization. If there's a vascular injury, you need to delay the ligament surgery and accept a stiff knee. Graft selection is important. Now, I'm lucky to go and operate and lecture in various countries. Not every country has allograft availability. Not every place has allograft availability. And therefore, you need to be able to do patella bone grafts, quadriceps grafts, hamstring grafts, and you may need to harvest the other knee. And you've got to be able to do all of these grafts and harvests and make sure you have experience of doing these. Leprade has written a lot about the multi-ligament knees as part of knee dislocation, and I would urge you to read his papers. He talks about a stress X-ray valgus, which is useful, and I can see the theory, but in my hospital, we can't reliably get them. But he mentions the stress and whether to do things or not, and I'll let you read up about it. But in my practice, we tend to get MRI, and we could get dynamic MRI scans. And these have great value. And if maybe you don't have access to such good scanners, then the simple stress testing can give you a lot of information, which is why I put this down here, and I urge you to read his paper. And then he also, in that paper, he describes his reconstruction technique, and I use a modified Leprade procedure, more or less for all my multi-ligament reconstructions. I'll do the posterolateral corner repair, and sometimes also carefully look for a deep MCL injury. A lot of the time on the MRI scan, an MCL injury is reported, MCL has been reported as normal because they've looked at the superficial MCL. But when you look at the deep MCL, it's torn and it can lead to ongoing instability. So please do look for the deep MCL and make sure that's intact. If not, you have to repair it. This is complex surgery. So tips and tricks: position the patient so you can have full flexion and extension. Have your plastic surgeons if there's a nerve injury. Take care to whip stitch the ligaments so they pass easily, and they don't fray when you put screws in. If you are lucky enough to have allografts, they can be prepared even while the patient is being anesthetized. Your assistants can start preparing them to minimize tourniquet time and operative time. Have your plan early so you avoid tunnel convergence and early protective range of motion. Incorrect positioning, and if your drapes limit your access, you will struggle all the way through. Oversizing the grafts is a problem. They get stuck and you will not enjoy the experience. I was stuck once for many hours because of this problem. Tunnel convergence, again, is something that's a major pitfall. Meniscal root injuries, the MCL, deep MCL injury, we've talked about this before. Again, if you haven't recognized this or not prepared or not be prepared with the equipment to repair this, you can lead to instability. Avoid neurovascular injury is easy, especially when you're drilling the posterior cruciate ligament. The neurovascular structures aren't far. You should do this under image guidance. There is a sequence of graft fixation. It can alter your kinematics. And again, Leprade's paper deals with that quite nicely. So thank you very much for your attention. That's my time up. And I thank you once again for allowing me to give my thoughts on knee dislocation. Many thanks.
Thank you so much, Mr. Qureshi, for this very interesting and illustrative talk. Thank you so much, sir.
It's a pleasure. I hope that was useful.
Mr. Rami is the moderator of this talk. We are waiting for questions from our dear audience and colleagues.
Thank you, Mr. Qureshi. I haven't yet got any questions, but the question in my mind about decision making, I know from my work with you that decision making for knee dislocation is quite tricky and challenging. When do you say to a patient that your injury is not fit for surgery and it is for knee replacement? What is the selection criteria for such patients?
Thanks, Rami. I think for the knee replacement question, I think it's degenerative disease of the knee. If it's someone with significant degenerative disease and they've got a multi-ligament injury, then going through the whole process of quite risky, invasive patient surgery to then have a knee that is still painful and is going to be a lot more stiffer is probably, in my view, too much to do. So if they've got degenerative disease, I would go for a stabilized knee replacement with high constraint. So that 74-year-old would ordinarily have degenerative disease and you'd go for a constrained knee. But she had no signs of arthritis whatsoever. She had no pain before. And I struggled in my mind to justify, and I discussed her with colleagues and they said, she's 74. No one had done a multi-ligament in a 74-year-old with good reason, because they're very rare. But in her, we did a multi-ligament. It was the best thing to do. She still hasn't got a knee replacement. She's got no knee pain. So degenerative disease is what will stop me doing a multi-ligament reconstruction.
Thank you very much.
Mr. Qureshi, I have a question, please, sir.
Sure, Professor.
If I have instability and I put the external fixator, what are the guidelines for putting the fixator and when to remove it? Is there a fixed time for removing it?
I think the main thing is to get an MRI scan and see whether the ligaments need reconstruction. So what I would do, if the ligaments need reconstruction, I would remove it early and reconstruct and stabilize the knee and get it moving. If there are no ligaments that are significantly injured, which is unusual, then the question is, do you need an external fixator at all? And in that case, this is where I would do the EUA in theatre, and only if it's unstable, put an external fixator on. If the external fixator is put on because there's been a vascular injury and a vascular repair, I tend to follow the guidance of my vascular surgeons, which tends to be between 6 and 8 weeks after the injury. But that's not to protect the knee per se, that is to protect the vascular repair.
Thank you, sir. Mr. Rami, we have questions.
Yeah, I received a question from Mr. Khaled Muhammad about knee dislocation in total knee replacement. Do you follow the same protocol or it is a bit different?
So the problem then is obviously you need to understand why the knee has dislocated. And you've got to then up the constraint. So if it's something, so I've had 2 knee dislocations in my practice. So it's always better to talk about your own practice than the dislocations that you've seen. So in my practice, one of the patients that I had a rotating platform primary knee replacement. She was discharged the next day because she was doing so well. And she flexed her knee to 140 degrees, right down to pick up the suitcase from underneath her bed, less than 18 hours after her operation, because our blocks and local was working so good. And she spun out. So that's a very different thing. So that is, she spun out. We then went back, I replaced it, and she still hasn't had a revision. This is about 5 years down the line now. Her knee's never been good. Her knee has never been good after that because it was a CR rotating platform. She's done her PCL, her medial lateral lateral ligaments were fine. So she really needs a constrained knee now because she had a CR knee, now the PCL is completely ruptured. The posterior capsule is ruptured. And I think with these knee dislocations, it's more the capsular rupture that gives instability rather than just the PCL. Because even with CR knees, if you damage the PCL, if you cut the PCL, sometimes with a tight rotating platform, what you have to do is actually release a bit of the PCL. So I don't think it's necessarily that the PCL is gone, but I think with that, such as the degree of that the knee is dislocated, the posterior capsule goes and all the stability goes. So I think a knee dislocation, the ultimate solution, unless it's because you've undersized, the other reasons now, that was that was the one that was under mine, okay? But the knee dislocations that I've seen from other areas, when you undersize the poly, or someone has used the wrong side implant, I've seen that. Cut the knee with it set on varus rather than valgus. So all sorts of, cut too much tibia, again, that's due to then balancing. And a lot of the times, the only correction for that is going to be increasing your constraint. Very few of those will go just with a poly exchange. The other one that of mine that dislocated is she was walking across her living room. This is about 2 weeks after our operation, really good until then, walked across the living room, tripped on a rug, fell on her knee, and the force of that then dislocated her knee. She then didn't present for 5 weeks. So she stayed at home because of COVID and being worried with a dislocated knee for 5 weeks. So she came, it's the most horrible x-ray of mine that I've ever seen. And then what I did, I took her to theatre. I thought maybe her foot, she had good neurovascular supply, CT angio was normal. And then all I did is I actually did a open MUA, released the adhesions, and then it was stable. She's now almost 5 months down the line of this, and she's completely stable. But I think it's because she got so stiff after 5 weeks with a dislocated knee that all the capsule and everything else is just stiffened up. So she's in her mid-80s, so we're not going to do anything more with her, and the knee is still reduced. So I think those are the two in my lifetime that my patients that dislocated for those reasons. Most of the reasons that I've seen are surgical and need to be addressed really with increasing constraint to a hinged knee.
Perfect, thank you very much. There's a question in my mind about tips and tricks for external fixation. So I'm now on call and I have taken the patient with knee dislocation to theater and I couldn't put it in a good position with a plaster. So I'm planning for external fixation. But I don't want the knee surgeon, the knee specialist like you, to be angry from my external fixation, because if I put it anterior, I will destroy the quadriceps. If I put it too short to the knee, it will be a stress riser if you plan for knee replacement. So what is your tips and tricks and advice for me while putting external fixator?
There are 2 types of fixator that you may use. One is for temporary fixation, so damage control. And what the primary thing there is to stay out of the knee joint. You could go anterolateral on the femur, and you could go anterior posterior on the tibia outside of the knee joint, and you'll be okay. So if you, as long as you're below the insertion of the hamstrings, you're okay. What you don't want to tether is anything around the tibial tuberosity and the patellar tendon. The quadriceps in itself isn't such a problem with if the knee's in extension. You just want to put a hint of flexion on. Don't put the knee in full extension. The patients don't like it. It causes them pain. So just a hint of flexion. You could go anterolateral or slightly anterior. If you go too lateral, the bars will hit the side of the knee, so you can't cross onto the tibia. So that's why you have to raise your pins. Now there's the LRS monorail system, or the LRS system, which is much heavier. And sometimes I've used that in the obese patient who is never going to have any reconstruction because of other comorbidities, and then they can actually weight bear on that, and they'll never have any sort of reconstruction. And then I'd go directly anterior on the femur and anterior on the tibia as well. But anterior to anterolateral on the femur is okay, but stay outside the knee joint.
Brilliant. Thank you very much. I don't have any more questions. Thank you very much.
Finally, I would like to thank Mr. Qureshi for joining us tonight in this very fruitful scientific night. Thank you so much, sir. It gives us a great honor.
It's a huge pleasure. Thanks very much.
Thank you.